Good afternoon, and welcome to the Thursday, August 23rd AMDA webinar, Macra, MIPS, and Apms, Current Requirements and Proposed Changes. Presenting today will be Benjamin Chin, Brittany LeCouture, and Molly McHarris. I will now turn the floor over to Alec Bartek, who is going to give formal introductions for all the speakers.
Hi, thanks everyone. Thank you, Lauren, for setting this up. I want to welcome everybody from the public policy standpoint to the webinar, and I especially want to thank the CMS staff who took the time out of what is a very busy time at the moment to join our organization to deliver this special webinar for AMDA members. On the phone with us today, as already mentioned, is Molly McHarris. Molly is a program lead at CMS. She is the lead for the Merit-Based Incentive Payment System, or more widely known as MIPS, which was a program under the Medicare Access and CHIP Reauthorization Act, which was much better known as the Macra legislation. Prior to this role, Molly led the development of policies and operations through the Physician Quality Reporting System, or PQRS, and the Electronic Prescribing Incentive Program. In this capacity, Molly provides leadership and input to a variety of aspects of the programs, including stakeholder engagement, operations, policy development, and alignment with other quality programs. Personally, I will say that I've heard Molly do this presentation many times in briefings, and I've had a chance to speak with Molly, and she's extremely knowledgeable in many of the areas, and has been a good friend to our organization and working with us to implement policies that we have been working with CMS. In addition to that, on the phone is Benjamin Chin. Benjamin is a graduate of Rutgers University and is currently a policy analyst specializing in healthcare policy working for CMS. Prior to joining CMS, Ben worked with the Thailand Institutes of Justice in Bangkok as the Henry Luce Scholar, where he conducted research on alternatives to incarceration for drug-involved offenders through the Asian region. Ben has also worked with Apms Associates, which is a well-known research organization in Washington, D.C., and the Substance Abuse Mental Health Services Administration prior to working with CMS. Finally, we have Brittany LeCouture, who's a health insurance specialist at CMS's CMMI. You may know that the Center for Medicare and Medicaid Innovation was established to test alternative payment models, and this is the center who is responsible for writing policies implementing such things as BPCI or the bundle program and many other areas. Since completing her JD at Georgetown Law Center, she has focused her career in healthcare law and policy. Again, I want to welcome all three of you and thank all three of you, again, which is a busy time. I want to remind the audience that when CMS folks discuss the proposed rule that is currently under the comment period, they will be able to answer in a very limited fashion because the law prohibits CMS officials to comment on rules that are during the comment period. The AMDA is currently drafting comments, and the questions may actually inform the comments we write prior to September 10th, which is the deadline to comment on the current proposed rule. But prior to them discussing the proposed regulation, which is currently out, they will also outline the current requirements, realizing that it is already August. But as you may know, the Macra requirements of participation started on January 1. So many of you are required to be participating or to get either incentives or penalties. And I will stop there. We have about 90 minutes, and I'm sure you want to hear from CMS. So please feel free to ask as many questions as you like. We will also be recording this session, so we will make the recording available. And feel free, if you still have questions of us at AMDA, please feel free to email me, and we're happy to get those answered and to hear your comments. With that said, we'll turn this over to Molly.
Thanks so much, Alex, and thank you everyone for being here with us today. As Alex mentioned, we have a lot of information to go over with you all, so I'm going to go ahead and jump right in. If we want to move to slide 3. Just as a reminder, what we will be covering today is an overview of the Quality Payment Program, the 2 tracks of the Quality Payment Program, the MIPS side of things, as well as advanced APM. And we'll be covering both the current requirements, as Alex is mentioning, for our second year of the program, 2018. And we also will be going over our proposals for the third year of the program. So a lot of information. Hopefully this resonates with you all, and happy to take any questions. So let's go ahead and move on to slide 4 and slide 5. So to start the Quality Payment Program, as many of you are aware, the Quality Payment Program was authorized by the Medicare Access and CHIP Reauthorization Act, which passed in 2015. The Macra did a couple of things. It repealed the sustainable growth rate methodology. It also sunsetted 3 legacy programs: the Physician Quality Reporting System, or PQRS program, the Medicare EHR Incentive Program for eligible professionals, or the Meaningful Use Program, and the Physician Value Modifier Program. Those 3 programs sunsetted, and Macra authorized the new Quality Payment Program, where there are 2 tracks for participation: the MIPS track, which I will spend time talking with you all about today, and then the APM track, which my colleagues Ben and Brittany will be going over. So we can go ahead and move on to slide 6. So as I mentioned, in the prior state before Macra passed, there were 3 legacy programs: the PQRS program, the VM program, and the Medicare EHR Incentive Program. Those programs have ended, and now MIPS or the advanced APMs are programs that most clinicians would be a part of. Moving on to slide 7. So our high-level timeline for the second year, but you'll see a similar slide to this when we talk about our year 3 proposals. So we are, as Alex mentioned, in the second performance period of calendar year 2018. Hopefully all of you are participating in the program. If you have not yet started participating, hopefully the information we're sharing with you today can help you on getting started within the program. So generally, performance should be occurring during the calendar year. Then you would need to submit your data to us by the first calendar quarter. Then we would issue feedback, and then your payments would be adjusted in calendar year 2020. And then moving on to slide 8. So what we do under the MIPS program is we assess clinicians' performance on 4 performance categories. That includes quality, so similar to the PQRS program; cost, so similar to the resource use component that was used under the Value Modifier program. The promoting interoperability performance category deals with usage of certified EHR technology, so for any of you who participated under the Meaningful Use program. And then improvement activities. This is a new category that was authorized under the Quality Payment Program, and this deals with practice improvements within your organization, which could include such things as after-hours care and expanded practice access. You'll note on this slide that each of these 4 categories has numbers associated with them, and those numbers add up to 100 total points. That's important because what we do under MIPS is we assign to each clinician something called a final score. And that final score can range from 0 to 100 points. And again, that score will be based off of performance in those 4 categories. Everyone wants their final score to be above the performance threshold. The performance threshold for the second year is at 15 points. If your final score is above the performance threshold, that means you'll be getting a positive payment adjustment. If it's below the performance threshold, that means you'd be getting a negative payment adjustment. And if it's at the performance threshold, you would get a neutral adjustment. And I'll go into all of this in more detail throughout the presentation. Moving on to slide 9, just a quick refresher of some of the terms and timelines that I'll be talking about here today. When I talk about a TIN, I mean a tax identification number, and that is the number used by the IRS to identify an entity. I'll also be mentioning an NPI, a National Provider Identifier. That's the 10-digit numeric identifier. used to identify clinicians. And we, under the Quality Payment Program, talk a lot about TIN NPIs. And that's the way that we identify you based off of you, your NPI, and your TIN, your organization that you're associated with. So there could be instances where if you as a clinician practice at multiple practices out of different organizations, you could have multiple TIN NPIs, and you could be eligible or excluded from participation in the program under each of those. Again, I'll go over this in more detail in some coming slides. Also, just want to mention the difference between our performance period and our payment years. So we are in the second year of the program. We're in our 2018 performance period. The payment year that would be associated with this is 2020. So that would be the year when we would actually update your claims based off of your performance in the associated performance period. Okay, those are the high-level basics, so let's keep moving on. So let's move on to slide 10 and slide 11 to start with who can participate in the second year of the program. So there's no change in who can participate from year 1 to year 2. The types of eligible clinicians still include physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. Also to note, when we talk about physicians under Medicare, we mean not only MDs and DOs, but also dentists, podiatrists, optometrists, and chiropractors. Moving on to slide 12, we do have a number of exclusions under the MIPS program. The one that we talk the most about is the low volume threshold exclusion. So first, to be potentially eligible for MIPS, you would have had to have been one of those clinician types I just mentioned, physician, physician assistant, et cetera. Then we would look to see whether you would be excluded from the program for a year. So we've increased the low volume threshold exclusion from the first to the second year based off of a lot of feedback that we heard from a variety of stakeholders that while the low volume threshold was excluding some clinicians, there were still many clinicians who had significant challenges in participating in the program. So we've increased the low volume threshold exclusion that you would only be eligible for MIPS if you bill more than $90,000 annually and see more than 200 patients. So moving on to slide 13, some of our additional exclusions that we have. I've already talked through the middle one there, the low volume threshold. The one on the left-hand side being newly enrolled to Medicare. What that means is that if you become newly enrolled to Medicare within our PACO system for the first time during the performance period, you're excluded just for that year. You also can be excluded from the MIPS track of the Quality Payment Program if you significantly participate through advanced APMs. Okay, let's move on to slide 14 to talk through some of our special statuses. So we have our base population of who's eligible for the MIPS program. Then we also have a number of things called special statuses that we can apply to a MIPS eligible clinician. If you have a special status, such as if you are ASC-based, ambulatory surgical center-based clinician, you are still MIPS eligible. It just means that in some of our performance categories, you have to do a little bit less. And I won't go through all of these, but happy to take any questions on any of these later on. Okay, let's move on to slide 15, our performance period for the second year of the program. The performance period did change from year 1 to year 2. In year 1, for those of you who participated, I will recall there was a pick your pace approach where you could participate for a minimal amount of time and still avoid a negative payment adjustment. For the second year of the program, we did make a slight increase to the requirements, where now for the quality and cost performance categories, participation should be for a 12-month period. Still for the improvement activities and promoting interoperability performance categories, the performance period is a minimum of a 90-day period. Okay, moving on to slide 16. So how you can participate for the second year. We still have our participation options of as an individual based off of your unique TIN and NPI combination. You can still participate as a group. That would mean if there are 2 or more NPIs part of your practice that have reassigned their billing rights over to the TIN, they can participate as a group. And then beginning in the second year of the program, we offered our virtual group option. Virtual groups are made up of solo practitioners and groups of 10 or fewer clinicians who can come together virtually to form a group. And as mentioned on slide 17, actually I think we can move on to slide 18. A couple other things to know about virtual groups. Virtual groups, that election by law has to be made prior to the beginning of the performance period. So we have our couple virtual groups for the second year of the program. If this is something that you all would be interested in for the third year of the program, again, by law, we do have to receive any of the virtual group elections prior to the start of the performance period. Generally, we treat virtual groups the same as groups, meaning all of the various submission mechanisms and ways that you can participate would also be available to a virtual group. Virtual groups can form without regards to specialty or location. We've kept the criteria really broad because we really want to have as many folks participate in the program as they can. So let's go ahead and move on to slide 19 for our submission mechanism. So under the 4 performance categories, there's various ways that you can get your MIPS data into us. You'll note that there are 3 common methods across the performance categories. That includes working with a QCDR, a Qualified Clinical Data Registry, working with a registry, or using your electronic health record if you have one available to you. There are other options available as well, but those are some of the common methods across the performance categories. I also want to note that for the cost performance category, no submission is required. We calculate the cost performance category based off of available in-house claims data. So let's go ahead and move on to slide 20 and 21 to start talking through the performance categories for year 2. So starting first with quality. So if you look at the left-hand side of the slide, you can see the basics. So quality will contribute 50 points towards a clinician's final score in the second year of the program. So where we are today. For the quality performance category, the requirements are that folks would need to select 6 measures. One of those measures would need to be an outcomes-based measure, or if an outcomes-based measure is not available, another high priority measure. And our high priority measures include outcomes measures, patient experience measures, patient safety measures, care coordination, and appropriate use measures. To select those 6 measures, you can do so from a set of around 270 measures, or we also have a number of specialty-specific measure sets. For each of the measures, the requirements for the second year are that they would need to have a 60% data completeness. A data completeness deals with the total amount of eligible patients that would fall under the measure, and we would want to ensure that you report the quality indicator for at least 60% of those cases. If you do not meet that threshold, the maximum number of points you could get for the given measure would be 1 out of 10 points, unless you're part of a small practice, and then you could receive 3 out of 10 points. Generally, for each measure under MIPS, you can get between 1 to 10 points. Let's move on to slide 22 for some more information on quality. So as I was just going over some of our scoring rules, we do still have some of our floors for the measures. The floors for the measures are in instances where either we cannot create a benchmark for a given measure, or if the measure does not meet case minimum, you can get 3 points. We also have bonus points available in the quality performance category for reporting on additional high priority measures. and if you report data and the quality performance category in an end-to-end manner using certified EHR technology. Moving on to slide 23. In the second year of the program, we also talked about topped-out measures. So a topped-out measure is a measure that has really high performance rates, meaningful distinctions between performance can no longer be measured. So what we did in the second year of the program is we instituted a process where we would identify and score differently topped-out measures, with ultimately having the topped-out measure being removed from the program on a 4-year life cycle. So first we identify the measure as being topped out, then we would apply a scoring cap, where instead of being able to receive a maximum of 10 points, you could receive a maximum of 7 points. Then after that scoring cap has been in place, by the 4th year, the measure would be removed. Okay, let's move on to slide 24 to talk through the cost performance category. So the second year of the program, this will be the first year that we measure a clinician's performance on cost. It will count for 10 points towards your final score, and it will be comprised of a Medicare spending per beneficiary and total per capita cost measure. These measures were used under the value modifier program, and we have provided information on these measures as part of your performance feedback. If you haven't taken a look at that, I would encourage you all to do so. We also have been working on developing new episode-based measures. We have proposed those for the 3rd year, but I will touch on that more when we get to that. Moving on to slide 25, the way that we calculate the cost performance category. Again, we calculate cost based off of in-house data available to us from claims. We will attempt to calculate both measures under the cost performance category, both the Medicare spending per beneficiary and total per capita cost measure, and each would equally contribute to the 10% that goes towards cost. If we can only calculate one of those measures, we would do that. If we are unable to calculate any of those measures for you, then the 10 points that would normally be attributed to cost would get redistributed to quality, with quality then counting for 60 points towards your final score. So let's move on to slide 26. By law, we are required, beginning in the second year of the program, to start measuring not only achievement on quality and cost, but also improvement. So essentially how you have how your performance has improved from one year to the next. For quality, we are measuring improvement based on the rate of improvement, such that higher improvement results in more points for those who have not previously performed as well. And we are measuring it for quality at the performance category level. For cost, we are measuring this at the measure level. The recent enactment of the Bipartisan Budget Act, however, has delayed cost improvement scoring until year 6. Okay, moving on to slide 27 to talk through the improvement activities performance category. Not too many changes here for the first to the second year. It's still, improvement activity still counts for 15 points towards a clinician's final score. We have over 100 improvement activities available within the inventory. Each of those either has a medium or high weight associated. What we need to receive in from clinicians on improvement activities is just a simple yes that the activity occurred. Moving on to slide 28, some additional changes that we made for the second year include finalizing additional improvement activities, including credit for using appropriate use criteria. We also still have designated some improvement activities that would be available for a bonus under the Promoting Interoperability Performance category. Moving on to slide 29 to talk through the Promoting Interoperability Performance category. This was also referred to previously as advancing care information, so you'll hear that mentioned sometimes as well. This performance category counts for 25 points toward the clinician's final score. In the second year of the program, performance is based off of a base, performance, and bonus scores. For the certified EHR technology requirements, 2014 or 2015 edition is allowed, but if folks exclusively use the 2015 edition, they're eligible for a bonus. Moving on to slide 30, there were some additional exceptions that we were able to offer in the second year of the Promoting Interoperability Performance category based on the passage of the 21st Century Cures Act. So under this category, we have certain exclusions that are automatic, and then we have some where you would need to request for this performance category to be reweighted. Those that are automatic are if you meet the definition of being a hospital-based MIPS eligible clinician, non-patient facing, or ASC-based. Also, if you are not considered a physician, so if you're a nurse practitioner, PA, clinical nurse specialist, or CRNA, the Promoting Interoperability Performance category will automatically be reweighted unless we receive data from you. For the exceptions that are available through an application, the new one we've offered in the second year of the program is if you're part of a small practice. We understand that there are significant challenges that face small practices. One of those is dealing with certified EHR technology. So those clinicians, they have the ability to file an exception. Also, if your EHR becomes decertified, you can ask for an exception as well. We also still have our prior hardship exceptions for this category dealing with insufficient internet access and natural disasters. Okay, let's move on to slide 31 and then 32. So we've talked through who's eligible and the performance categories. So circling back to these 4 performance categories, there's a total of 100 possible points. Again, remember that you want your final score to be above the performance threshold. And as mentioned on slide 33, the performance threshold for year 2 has increased to 15 points. So again, ideally, everyone's final score will be at or above the performance threshold, because then that means you would be getting a neutral or positive payment adjustment. By law, the total amount of payments that are available to be distributed has been increased from 4% to 5% in the second year of the program. We also still have our exceptional performer performance threshold, which is set at 70 points. Macra, the law, has allocated a separate bucket of $500 million that we can distribute annually for clinicians who have exceptional performance. So as reflected on slide 34, if your performance is at or above 70 points, you would get a MIPS positive adjustment that would be greater than 0%. So you would be getting a positive adjustment, and you also could be getting the exceptional performer bonus. Okay, let's move on to slide 35. Just a few more things from me on year 2. We also have offered in year 2 a complex patient bonus. We understand that many of you care for really medically complex patients. So we have a bonus point structure that's available, which can be up to 5 bonus points for clinicians who treat complex patients based off of dual eligibility and HCC risk score. To be eligible for this bonus, you need to participate and submit data in at least one performance category. Moving on to slide 36, we also have a small practice bonus. Again, we understand that there are a number of significant challenges that face clinicians who are part of a small practice. So if you are part of a small practice, you can get 5 bonus points towards your final score. Again, to receive this bonus, you just need to submit data for at least one performance category. And then on slide 37, our facility measurement option. So we finalized this as part of our year 2 rulemaking, but it's not actually available until year 3. So how we've approached facility measurement initially is clinicians who practice at facilities. Specifically, we've focused on working on this for the hospital value-based purchasing program to start with. So clinicians who practice in a hospital and also participate in the hospital value-based purchasing program, that we have the ability to use for performance on measures under the HVBP program for the quality and cost performance categories. So again, we've finalized this option as part of our year 2 policies, but we've expanded upon it in year 3. I will circle back and touch on this in a little bit more detail as I start talking through year 3, because we are explicitly looking for some feedback from you all on ways that we can further expand out this option in the future, specifically into the post-acute setting. That's something we're really interested in hearing feedback from you all on ways that we could expand this out to work in the post-acute setting. So let's go ahead and move on to slide 38 and slide 39 to talk about the Bipartisan Budget Act that passed this year. So I mentioned this earlier, but the Bipartisan Budget Act, it did a handful of things. The things that it did that impact the quality payment program deal with, first, the way that under the low volume threshold prior to the Bipartisan Budget Act, we included not only all of your covered professional services into those calculations, but also all of your Part B charges, including Part B drugs. The Bipartisan Budget Act changed that, where now the low volume threshold is only assessed based off of your covered professional services. Also, when we issue the year 1 payment adjustment in 2019, that will only be applied to covered professional services, not to all of your Part B items and services. The Bipartisan Budget Act also gave us additional flexibility on where we can set the cost performance category for years 3, 4, and 5. Prior to the passage of the BBA, cost would have had to contribute 30 points towards your final score in year 3, but we have additional flexibility where it doesn't have to be set at 30 points until year 6 of the program. And then lastly, the Bipartisan Budget Act gave us flexibility on where we can set the performance threshold. Without the passage of the Bipartisan Budget Act, the performance threshold would have had to have been set at the mean or median by the 3rd year of the program. Now we have flexibility on not setting it at the mean or median until year 6 of the program. And as we jump into slides 40 and 41, we did take advantage of the flexibilities offered to us under the Bipartisan Budget Act as part of our proposals. Okay, so hopefully everyone has a better understanding of MIPS Year 2. So I'm going to go ahead and talk through the MIPS Year 3 proposals. So as reflected on this slide, the proposed rule with the quality payment program policies went out on display on July 12th. As Alex mentioned earlier, the comment period closes September 10th. We really are interested in all of your feedback on our proposals. I know AMDA will be submitting their letter to us, so we're very interested in hearing and seeing what you all have to say based off of what we've proposed. Moving on to slide 42, the timeline slide, which is very similar to the timeline slide I had earlier in the presentation. So you can see what the proposed timeline could look like for year 3. It's really similar to what it looks like for year 2. Performance would be occurring in 2019. You would have the first calendar quarter after that to submit to us your data. We would issue feedback, and then payments would be adjusted in 2021. Moving on to slide 43. So who's eligible for year 3? We still have our same set of eligible clinicians, again, physicians, PAs, NPs, CNSs, and CRNAs, but we've also proposed to expand out to new eligible clinician types in the 3rd year of the program, specifically physical therapists, occupational therapists, clinical psychologists, and clinical social workers. Also, moving on to slide 44, we have made some additional proposed changes to the low volume threshold. We made 3 overall changes to the low volume threshold. The first is to maintain compliance with the Bipartisan Budget Act, which I talked about earlier. So again, that the low volume threshold would be based off of covered professional services instead of all of Part B. The second proposed change that we made to the low volume threshold is to not only account for the total amount of billing and patients that clinicians see, but also the total number of services. So as you can see on slide 44, we still have the low volume threshold at 90,000 in billing, 200 patients, but we've also proposed to add 200 services. One of the common questions that we get since this proposal has come out is, what do we think of as a service? Typically, when we think of a service, we would think of a claim line. And as you can imagine, if you are a clinician and you see a patient, you could see the one patient, which would count as one patient towards your patient count. But during that time that you have with a patient, there could be multiple services that are rendered. Moving on to slide 45, the additional proposed change that we've made for the low volume threshold is the ability for clinicians to opt in. So what that means is that of those 3 elements of the low volume threshold, the 90,000 in charges, the 200 patients, and 200 services, if you meet and exceed all of those, you're eligible for the MIPS program. If you fall below all of them, you are not eligible for the program. But if you meet 1 or 2 of those, but not all 3, you have the ability to opt in. And if you choose to opt in, you would have the choice to be a MIPS eligible clinician. And if you make that choice, that means that you would be subject to all of the MIPS rules, including the payment adjustment, which again could either be positive or negative. Okay, let's move on to slide 46 for an example of the opt-in approach. So if you are, for example, a physical therapist, and if you build $100,000 annually, so you've checked that box, you provided 201 cover professional services, so you've met that element, but you only saw 100 patients. Since you did not exceed all of the 3 elements, you have the choice to opt into the program. If you choose to opt in, again, you would be considered MIPS eligible, and again, you would then be subject to the MIPS program and all of our rules and potential payments that are associated with it. Okay, let's move on to slide 47. One of the other changes that we've made in this proposed rule is a little bit of cleanup. Under the MIPS program, we have a number of determination periods. Prior to this proposed rule, we had separate determination periods for each of our special statuses. And what we've done is we've proposed to consolidate those determination periods into one set time frame. We've also shifted it from running from September through August to running on the fiscal year. We feel that that's just a little bit easier for folks to understand. Moving on to slide 48, some of the other changes that we've made, again, as part of our cleanup and from what we've learned over our experiences of the first year and a half of the program, is that the way that we talk about submission mechanisms as an all-inclusive term isn't actually the way that data comes into us. So historically, we've talked about a registry or an EHR as not only the way that you can collect the data, not only the way that you could submit data to us, but it also could also be referencing a third party that you may enter into a business agreement with. So what we've done in this year's proposed rule is we've proposed to expand out our terms. And so as reflected on slide 49, we now have a collection type, submission type, and submitter type. We have heard some comments that these terms may not be the best words, so we definitely welcome feedback on better terms that we should be using here. But what we mean when we say collection type that would refer to a set of quality measures with specifications and data completeness criteria. So we have eCQMs, we have MIPS CQMs, which were previously referred to as registry measures. We also have QCDR measures, Part B claims measures, web interface measure, the CAPS for MIPS survey, and administrative claims measures. We also have a submission type, which deals with the mechanism by which a submitter can submit data to CMS, including a direct type, which could be using an API, an automated programming interface, for data to come directly to us. It also could include the ability for you to log in to our website and upload and submit data to us. And then our submitter types include eligible clinicians, groups, or third-party intermediaries. Okay, moving on to slide 50. So this slide is from the rule, and this reflects under the performance categories the various submission types, submitter types, and collection types available to individuals. And then slide 51 shows those options that are available to groups. So you'll notice there are a few distinctions between what's available to individuals versus what's available to groups. Okay, moving on to slide 52. So virtual groups. As I mentioned earlier, virtual groups was new for the second year of the program. For the third year of the program, the same requirements are still in place. All elections still need to be sent to us by December 31st, prior to the beginning of the performance period. So if this is something you're interested in for year 3, we would need to receive those applications no later than December 31st, 2018. And we did make a few changes regarding how people can contact us. Specifically, they can come to us through our service center. And then moving on to slide 53, our performance period for the third year, there is no change here. So the performance periods that we have for the second year are the performance periods we would have for the third year, which is 12 months for quality and cost, and 90 days for improvement activities and promoting interoperability. And moving on to slide 54, we did make some proposed changes to the performance category weights. So again, remember the performance category weights, these are the numbers that sum up to 100, and this is how we assess your performance and assign your final score. Quality, we've proposed to count for 45 points, and cost to count for 15 points. Okay, let's move on to slide 55 and 56 to start talking through some of the other changes we've proposed to the performance categories. Starting first with the quality performance category. Again, the major change that we've proposed here is that quality would count for 45 points towards your final score in year 3. We have the same basic requirements of 6 measures, one needing to be an outcome measure. If an outcome measure is not available, a high priority measure. We have also proposed to add the designation of opioid measures to high priority measures. And we also have shifted that small practice bonus I was talking about in the second year of the program that was available at the final score to now fall within the quality performance category. Okay, let's move on to slide 57 to talk through cost. Similar to quality, not too many changes here. The most significant change is the contribution towards the final score, which has been proposed to be at 15 points. We also have proposed to add 8 episode-based measures, which would also be part of this category, in addition to the Medicare spending per beneficiary and total per capita cost measure. Moving on to slide 58, improvement activities. Very minimal changes were proposed here. We do still have the this performance category contributing 15 points towards a clinician's final score. We did add 6 new improvement activities. We proposed to modify 5 improvement activities and proposed to remove 1 activity. And moving on to slide 59 for the promoting interoperability performance category. We have made a number of significant proposals here. We've really overhauled this category. So the way it works in year 2 is performance is based off of a base, a performance score, and a bonus score. And you would have to fulfill the base score requirements to earn a promoting interoperability score. Now for year 3, that's been eliminated, and it's a performance-based scoring system at the individual measure level. Each measure is associated with certain objectives. Moving on to slide 60, we have one set of objectives and measures based on 2015 edition certified EHR technology. In the 3rd year, clinicians must use 2015 edition certified EHR technology under this performance category. We have 4 objectives we're focusing on: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. Moving on to slide 61, again, it's a performance-based scoring approach. Each measure would be scored on performance for that measure or a yes or no. There are exclusions that can be claimed for certain measures. If those are claimed, the points would be redistributed to other measures. And moving on to slide 62, additionally for promoting interoperability, we have the same reweighting exclusions that I talked about earlier. We've also proposed to expand the automatic reweighting exclusion to the new clinician types we've proposed: PTs, OTs, clinical social workers, and clinical psychologists. Okay, moving on to slide 63. So the performance threshold that we've proposed for year 3 is at 30 points. So again, remember the performance threshold is the number that you ideally want to have your final score at or above. So again, it's proposed to be set at 30 points for year 3. We've also proposed to increase that exceptional performer bonus from 70 points to 80 points. And the payment adjustment, again, has increased by law from 5% in year 2 to 7% in year 3. And moving on to slide 64, here's this breakdown again of what your scores could look like. The one piece I do want to note, which I didn't mention earlier, is that by law, if your final score is in the lowest quartile, you automatically get the maximum negative adjustment. So as you can see on the bottom row of these tables here, for year 2, if your final score is at 3.75 points or lower, you automatically get the negative 5% adjustment. For year 3, if we finalize a 30-point threshold, that would be at 7.5 points. So we really want folks to try to avoid that to the extent they can. Okay, and let's move on to slide 65, the last slide for me on MIPS. So also within this proposed rule, we have done some comment solicitation. And so what comment solicitation means is it's not a proposal that we would implement or finalize for the 3rd year of the program, but these are things that we're thinking about for the future. So one of the things that I briefly mentioned earlier, but we're really interested in your guys' thoughts and feedback on, is the ability to expand out our facility measurement option into the post-acute space. We also are looking at expanding this out into the ESRD space as well, but again, really interested in thoughts and feedback that you all may have on ways that an option such as this could work in the post-acute space. We also have put a number of questions out there in regards to the quality performance category. We understand, based off of feedback we've heard from many of you, that this performance category seems overly complex and confusing. That's not our intent. We want to have this category be meaningful. So we're really interested in ways that we can really rework and reapproach this category for the future. We also have heard for subgroup reporting that many large groups want to have the ability to participate at a subgroup level. So we're interested in ways that that could be implemented. And lastly, we're really interested in ways that we could have measures or activities that could span multiple performance categories. We know under MIPS there is performance on 4 distinct categories, but we do believe that there are certain ways that we could have closer alignment across the performance categories, and so we're really interested in your thoughts and feedback there as well. Okay, I've done a lot of talking, so I am going to stop and turn the presentation over to my colleague Benjamin Chin to talk through alternative payment models. Ben?
Great, thanks Molly. So we have quite a bit of material to go through on the alternative payment model side as well. The way I have this structured is first I'll talk about advanced APMs and then the proposed year 3 changes for advanced APMs. After that, I'll discuss the all-payer combination option, including other payer advanced APMs, and some of the proposed year 3 changes pertaining to that portion of the advanced APM track. And then I'll finish up talking about MIPS APMs and the APM scoring standard, and then changes that we proposed for year 3 there as well. So to dive right in, getting into alternative payment models, the Macra definition of alternative payment model is slightly different than definitions that had been coming out of CMS before. Macra defined APMs, broadly speaking, as any CMMI Innovation Center model, the Medicare Shared Savings Program, demonstrations under the Healthcare Quality Demonstration Program, and then any other demonstrations that are required by federal law. Moving on to slide 68, I think it's important to note that there are those general alternative payment models, which are any models in those categories I just mentioned. And then a subset of alternative payment models are advanced APMs, which I'll get into in a little more detail in a few slides. And then there's also MIPS APMs, and I'll explain the MIPS APMs criteria a little bit later as well. Moving along to slide 69. Advanced APMs, generally speaking, meet 3 criteria, and we finalized these 3 criteria in calendar year 2017, so that's our initial year of rulemaking. The first criteria is that they require participants to use certified EHR technology. The second is that they must provide payment for covered professional services based on quality measures comparable to those used in MIPS. And then third, they must require participants to bear more than a nominal amount of financial risk. And I'll get into that financial risk criteria in a little bit more detail as well. Moving along to slide 70, in addition to the general nominal risk standard, we also finalized in the first year's rulemaking a definition of a medical home model, and then separate medical home model, financial risk, and nominal amount standards. And these elements here were our definition of a medical home model, and the only current medical home model that we offer that is an advanced APM is the Comprehensive Primary Care Plus model, generally referred to as CPC Plus. Moving along to slide 71, these are the advanced APMs that are in operation in calendar year 2018. There are 9 here. I will say that there is one model here that's not mentioned, which is the Vermont Medicare ACO model, which for calendar year 2018 is actually considered to be a part of the next generation ACO model. But these are our offerings for calendar year 2018. This was an increase in the number of advanced APM opportunities. In calendar year 2017, we only had 6 advanced APMs. In calendar year 18, we have 10 advanced APM opportunities. Moving along to slide 72, I just want to briefly cover what a qualifying APM participant is, or a QP. These are eligible clinicians who are participating in our advanced APMs that through participation in APM entities have reached the requisite QP thresholds to earn the 5% APM incentive payment. As a reminder, in calendar year 2017 and 2018, the QP thresholds were either 25% of payments or 20% of patients that you saw through your advanced APM in order to reach or attain QP status. Again, QPs earn the 5% APM incentive payment in the payment year, and they're also excluded from MIPS reporting and the MIPS payment adjustments. Moving along to slide 73, this slide here details the financial risk criterion that I mentioned before. That is one of the 3 advanced APM criteria. In the first year's rulemaking, we established a general nominal amount standard and then, like I said, a special medical home model nominal amount standard. The general nominal amount standard had two parts to it. That advanced APM, or an APM in order to be an advanced APM, needed to require a total amount of risk that was equal to either 8% of Medicare Part A and B revenues, or 3% of the expected expenditures for which a APM entity, or really a participant, is responsible for under the terms of an APM. The medical home model nominal amount standard differed, and it actually had lower amounts of risk that were tied to revenue. So under the medical home model nominal amount standard, there was the revenue at risk needed to be 2.5% starting in 2017, then it ramped up slowly to be 5% of Medicare Part A and B revenue in 2020 and later. In year two, though, we finalized some changes to this financial risk criterion. So moving along to slide 74. So what we did in last year's rule for 2018 is we actually extended the revenue-based nominal amount standard, so that 8% standard. It had only been finalized for performance periods 2017 and 2018. We had extended that through performance period 2020. We had actually sought comment on increasing that standard to either 10% of revenues or 15% of revenues, but opted to not increase that standard and instead extend it at 8% through performance year 2020. We didn't make any changes to the expected expenditure standard. Moving along to slide 75, we did make one change, and this is pertains to the medical home models. In year one, we also had this policy, we called it the 50 clinician limit policy, where for performance year 2018 and thereafter, the medical home model financial risk standard would only apply to APM entities that had fewer than 50 eligible clinicians in their parent organization. And again, this was only applicable to the comprehensive primary care plus model. But what we did last year for year two is we exempted 2017 participants in the comprehensive primary care plus model from the application of the 50 clinician cap. So that policy then only applies to 2018 starters in the CPC plus model. Moving on to slide 76. We did also make a change to the medical home model nominal amount standard in year two. What we did is we actually delayed that slight increase year over year in the medical home model nominal amount standard, so that in 2018, the revenue at risk remained at 2.5% of the average estimated total Medicare Part A and B revenues, and then we started the increase after that, so that in 2021, it would be 5% of revenues that would need to be at risk. And so moving along to slide 77, those were the major changes that we made for year two, and now I will go into the changes that we proposed for year three that pertain to advanced APMs. The first change deals with that first advanced APM criterion. It's the cert use threshold. So in year one, and this was applicable for year one and year two, to qualify as an advanced APM, a payment arrangement must satisfy the cert use threshold criterion that at least 50% of eligible clinicians in each APM entity were using cert. What we're doing this year is we propose to increase the cert use threshold criterion so that 75% of eligible clinicians in each APM entity must use cert. This actually has no change or doesn't affect any of our advanced APMs to date. It's just a change in the number of clinicians that would need to use cert. Moving along to slide 79, we also made a change to that second advanced APM criterion, the one that payment must be based on quality measures that are comparable to those used under MIPS. And this change was really just to streamline our definition of what a MIPS comparable measure was. Previously, for years 1 and 2, we had a definition that had 5 criterion. So we streamlined that definition to only have 3 criterion to be effective in 2020, that the quality measure that an advanced APM must base payment. It must either be on the MIPS final list, it must be endorsed by a consensus-based entity, or otherwise determined to be evidence-based, valid, or reliable by CMS. So moving along to slide 80, we also made a similar change to the outcomes measure requirement that we have for advanced APMs. So that requirement is, in addition to basing payment off one quality measure that's comparable to MIPS, there also needs to be at least one outcomes measure used if one is applicable and available for the APM. And so that measure also needs to meet the requirements to be a MIPS comparable measure, and we updated those requirements to match the general quality measure requirements. So the last change on slide 81 that we proposed pertaining to advanced APMs for year 3 is we propose to maintain the 8% revenue-based nominal amount standard through performance period 2024. Again, we had only proposed to extend that revenue-based nominal amount standard through performance period 2020 last year, and so we are now extending it an additional 4 performance periods through performance year 2024. Okay, moving on to slide 83 and switching gears a little bit. Now I'll give an overview of the all-payer combination option and what we finalized for year 2, and then I'll get into the changes that pertain to the all-payer combination option and other payer advanced APMs for year 3. So as a refresher, the Macra statute created 2 pathways for clinicians to become QPs. What I was just referring to with advanced APMs is all under the Medicare option. And so this is, meeting the requisite QP thresholds through participation in Medicare advanced APMs. What the all-payer combination option allows, beginning in performance year 2019, it allows for eligible clinicians to achieve QP status based off their participation in advanced APMs, but then also other payer advanced APMs with non-Medicare payers. On slide 84, we detail the additional payer types that may qualify as other payer advanced APMs. And those are Medicaid, Medicare health plans, which include Medicare Advantage, and then payment arrangements aligned with CMS multi-payer models. And so our 2 current CMS multi-payer models are OCM and CPC Plus. And then lastly, other commercial and private payer models. Next slide. Actually, can we go to slide 85? So similar to advanced APMs, there are also other payer advanced APMs, and they actually have criteria that mirror the advanced APM criteria. So payment arrangements with other payers or non-Medicare payers, in order to be advanced APMs, they must also meet these 3 requirements, which they use certified EHR technology, quality measures, or base payment on quality measures comparable to those used in MIPS, and their participants must bear more than a nominal amount of financial risk as well. Moving along to slide 87 to explain some of the changes that we proposed for the all-payer combination option and other payer advanced APMs for year 3. We are also doing a parallel change for the cert use threshold, so that as of January 1st, 2020, the number of eligible clinicians participating in the payment arrangement who must be using CERT is also 75%. So we also did that increase from that 50% CERT use threshold to the 75% CERT use threshold. Next slide. We also made a change, though, to how other payers can meet, or other payment arrangements can meet the CERT use threshold. Previously, we finalized that the payment arrangement would have to have CERT use as a requirement of the contract or the payment arrangement. We have now modified that requirement so that other payers and other payer payment arrangements can meet the CERT use threshold by just demonstrating that CERT is met at the required threshold level. So they can do that by submitting to us documentation or evidence that CERT is being used, rather than having it be a requirement of the contract. Next slide. We also made a parallel change to the revenue-based nominal amount standard for other payer advanced APMs, which was also set at 8% through performance period 2020. We extended that through performance period 2024 as well. Moving along to slide 90, last year we created a payer-initiated process in order to prospectively assess other payer payment arrangements and determine whether or not they met the criteria to be other payer advanced APMs. So this calendar year in 2018, we have been collecting payment arrangement information from state Medicaid agencies, Medicare health plans, and then CMS multi-payer models to make these determinations. What we did not allow in the first year of the payer-initiated process is for general commercial payment arrangements to be submitted for other payer advanced APM determination. And so what we are doing in calendar year 2019 for the 2020 QP performance period is we're going to open it up to kind of all commercial payer models to be submitted for other payer advanced APM determinations. Next slide. We also heard from stakeholders that it would be helpful if CMS could do a multi-year determination for other payer advanced APMs. Many of the payment arrangements that are offered by non-Medicare payers exist for multiple years, like CMS's advanced APMs. And so we heard that rather than having a year-over-year submission process, it would be better if CMS could make a determination that lasted the duration of the payment arrangement. So we've altered our payer-initiated process that beginning in 2019 for performance year 2020, we will make multi-year determinations for models that span multiple years, and that submitters or payers will have to attest that there are no changes to those models. Next slide. So I think we can move on to slide 93. And now I'll switch gears again, and I'll talk about MIPS APMs and the APM scoring standard. So just as a refresher, the APM scoring standard offers a special, minimally burdensome way for clinicians who are participating in APMs to be scored under MIPS. And these are for clinicians who do not meet the requirements to become QPs. So the APM scoring standard is available to eligible clinicians participating in APMs that meet these three criteria, and we call these APMs MIPS APMs. So generally speaking, it would be APM entities that have to sign an agreement with CMS per the terms of the APM. The APM entities keep participation lists, and the APMs base payment incentives on cost utilization and quality. So for instance, our comprehensive care for joint replacement model, they do not keep clinicians on participation lists, and so that model is not an advanced APM. Sorry, it's not a MIPS APM. Moving along to slide 95, the category weighting for MIPS APMs under the APM scoring standard is different than the performance category weighting for general MIPS. Also in the transition year, we had, under the APM scoring standard, we had different performance category weighting for our ACO models, as you can see on this slide, than we did for other MIPS APMs. In year two, what we did is we aligned the performance category weighting for all MIPS APMs to be 50% quality, 0% cost, 20% in the improvement activities category, and then 30% in the promoting interoperability, was formerly called the advancing care information performance category. Next slide. We also made one other significant change into the APM scoring standard in 2018, and that was we established a fourth snapshot date of December 31st for full TIN APMs, and so this is for the Medicare Shared Savings Program. And this is only to determine MIPS APM participation. So this fourth snapshot allows us to look at clinicians who joined a Medicare Shared Savings Program ACO between September 1st and December 31st for the purpose of applying the APM scoring standard to those eligible clinicians in those ACOs. Moving along to slide 97. These are the changes that we have proposed for year three that pertain to MIPS APMs and the APM scoring standard. We made one small change to the third MIPS APM criteria. We just reordered the wording of the criterion, so that would clarify that the cost utilization part of the policy is broader than specifically requiring the use of cost utilization measures. Next slide. And the last change we made here, and this is somewhat of a minor change, but we aligned the promoting interoperability reporting requirements under the APM scoring standard so that MIPS eligible clinicians in any MIPS APMs could report PI in any method that is permissible under MIPS, so either at the group or the individual level. Previously, under the shared savings program, the promoting interoperability performance category needed to be reported only at the group level, so we've just created additional flexibility for participants in the shared savings program. And that's it for year 2 and year 3 proposed policies for advanced APMs.
Thanks, Ben. This is Molly. I'll just quickly go over the help and support slides. Just want to make sure that folks are aware that we do have a lot of help and support available. So we have free technical assistance available throughout the country. We have our service center as well as our website at qpp.cms.gov. If you have not gone to that website yet, I would highly recommend that you go there. There's a lot of information out there. We have the ability for you to enter your NPI, and we provide back information on what we know about you in relation to the quality payment program, including whether or not you are eligible or excluded from MIPS, or if you may be part of an APM. We also have free technical assistance to folks that are part of a small practice, but also for people, again, across the country through our QIO and QUIN networks, as well as through our Transforming Clinical Practice initiative. And then I think the last piece we just wanted to touch on slide 101, there was a lot of slides we had to cover today, was again just re-emphasizing that for all of the proposed rule policies that Ben and I went over today, we do strongly encourage all of you to either submit your comments to us directly or work with AMDA to get your feedback in on our proposed policies. We do need to receive those by September 10th. So I think that's everything we had to cover today. So Alex or Lauren, I'll turn it back to you guys. Thank you.
Okay, great. Thank you for the presentation. We can now take the opportunity to answer any questions that any of the participants might have. If you have any questions, you can enter them into your chat box and we'll address them. And then we can also address any of the questions that have already come through. So let's see. One question is, how will MIPS work with the PCP, the Maryland Primary Care Program? Is this in addition to MIPS or in place of? It seems like lots of reporting will overlap, and will CMS incentivize the same practitioner potentially for both programs?
Hey, this is Ben. I can answer that question. So the Maryland Primary Care Program for 2018, that's the Care Design Program, and then in 2019 for the Maryland Total Cost of Care Program, for both the Care Design Program and the Primary Care Program. They will be, it'll be both an advanced APM and also a MIPS APM. And so, like we do for other MIPS APMs, we will use the quality reporting that's required under the model for those participants, and they will benefit from the special.
So this is Alex. There was a question that came in. There was a glitch on reweighing the ACI measure to quality when the hardship was filed. Do you have any updates when that will be corrected in the performance feedback report?
Sure, this is Molly. So you're correct, Alex, that when performance feedback for year 1 was issued in July of this year, We did hear feedback from a number of folks that a few things were looking a little funny within their reports. One of those was dealing with the Advancing Care Information, or renamed the Promoting Interoperability Performance category, hardships and how those were applied. That is an issue that we are aware of and we're working on rectifying. I don't have additional details on exactly when that information will be updated at this point, but we'll be sure to let you know, Alex, as well as everyone through our normal listserv mechanisms once we have a bit of a firmer timeline of when those updates will be in place.
Okay, great. Are there, again, a reminder, please submit your questions so that we can ask them directly. But while we're still waiting for those to get queued up, Molly, do you mind talking a little bit about the proposal to include SNF-based specialty set? And it probably goes to the question that somebody had asked earlier about how do you find measures, but if you're a SNF-based clinician, how do you find those applicable measures? But can you talk a little bit about both of those?
Sure. So we did make proposals this year to expand out new specialty sets. I think it was a SNF specialty set, and I apologize, I can't remember what the other one was as well. But so we've proposed that those specialty sets would be part of the quality performance category. It is still in the proposed state, so we definitely want your guys' feedback on whether those measures that we have included as part of the specialty set, if they make sense for your particular specialty. Depending upon how the comments shake out, we would either finalize that policy or not finalize that policy. If it does get finalized, that would be as part of our rulemaking process. I do want to emphasize again our website, the qpp.cms.gov site. We have as part of that site a measure shopping cart where there's the ability for you to look through all of our various measures, either by a certain condition or by specialty, and find the measures that are most applicable to you, assuming, or if that specialty set does get finalized, those would be updated in that site later on in the year.
Okay, great. And certainly AMDA will be submitting some comments in terms of what we would recommend to be published as part of that set. So appreciate that. Another question that looks like is a follow-up to the Maryland Primary Care Program. Looks like there's several questions on that. And the question is, so if my group is in MIPS now, what is the benefit of switching to a MIPS APM or the Maryland Primary Care Program? Will the incentives be any different? And this particular group is a small group of less than 15 practitioners.
Yeah, this is Ben again, and so I can address that. So I think to start, benefiting in an APM, particularly the Maryland Primary Care Program, I think the decision to benefit an alternative payment model, there are certain benefits at the APM level for participation. But in terms of the difference between MIPS and the MIPS APM, again, the only difference is when you're participating in a MIPS APM, there is the special APM scoring standard. So there is some burden reduction in that we can repurpose the quality performance data that is reported under the APM for the purposes of MIPS. In terms of what is more appropriate, I don't think we can say, but those would be the benefits in terms of the distinction between participating in regular MIPS versus a MIPS APM. Molly, I'm not sure if you want to add anything else.
Yeah, agree with everything Ben has said. The other piece that I would add is, one of the goals of the quality payment program and, kind of the movement towards value overall within the industry is to try to get more and more clinicians into APM to the extent that it makes sense for them to be in an APM. Regarding some of the, differing incentives or financial benefits, under the MIPS program, by statute, we have certain amounts of payments that can be distributed, which I talked about for year one. There was a total amount of 4%, which could be distributed. Year two, it's 5%. Year three, it's 7%. It does increase over time On the APM side, if you become, as Ben was discussing, a qualified participant, you can earn a 5% lump sum incentive, but there are also a number of other benefits of being part of an APM, of additional cost savings that as a practice you would have just by virtue of participating within the APM. So there's, as Ben said, we can't really give anyone specific guidance as in this is what you should do, but these are all factors that we would recommend you take into consideration when you make this choice.
Great, thank you. And if anybody has any follow-up questions on anything that's been heard, again, submit your questions in the chat. While maybe those are populating, you mentioned the proposal for facility-based scoring for post-acute care. Can you maybe elaborate a little bit in terms of what kind of questions you're looking to get answered? I know you talked with us a little bit before about that, but if you could elaborate on some of the questions that you'd want to have feedback on from our group.
Yeah, sure. Let me just try to pull that up again real quick. Apologies. But while I'm pulling that up and while we're waiting for more questions to come in, I can always talk. So as I mentioned before, as part of our facility measurement option, which again, for the initial years of the program, we have it focused on the hospital value-based purchasing program, again, considering that that program has been around for many, many years. Clinicians have a lot of experience participating in that program. But we are looking at expanding out the facility measurement option to other settings, specifically into the post-acute setting or ESRD settings. So some of the questions that we are considering, and again, we really are really interested in all of your guys' feedback on this, is when we look at all of the different steps and processes that we've set up to have facility measurement work for the HVBP program, do we think those similar steps or processes would work in a post-acute space? So for example, one of the questions that we're looking for feedback on is which measures should we use? So the way we've done it for the HVBP program is we've taken all of the measures that are available within that program. We take the total performance score and transform that to apply to the quality and cost performance categories. When we think about all of the various post-acute programs, all of the various QRPs, and all of the various measures that are available there, which ones would make the most sense for us to use? Should it be all of the measures, a subset of the measures? How can we identify which of those measures do we feel are really influenced by clinicians? Some of the other items that we are considering and we want your guys' feedback on is, again, looking at the post-acute space, there's a lot of settings there. So should we be focusing on one certain area, or such as inpatient rehab facilities or LTECs, or are there other areas we should be focusing, such as SNFs, et cetera? Some of the other questions that we have also deal with how we identify you for this particular option. So would the approach that we take, again, currently for facility measurement, would that work in a post-acute space where we identify you based off of certain place of service codes? So again, these are all questions that we are mulling over, and we really want your guys' feedback on ways that we can work on addressing and solving for these. I also will note that, again, as you all, as being post-acute clinicians, you are much closer to all of this work than we are, and if there are other things that we should be considering on expanding out this option that we have not thought of or considered, please share those with us so we can try to make this work in a future year. So I hope that helps a little bit.
Yeah, no, I think that's very helpful. Again, if anybody has questions on a reaction to what Molly just stated, please utilize the chat feature. I will just mention that, of course, AMDA is actively working on a response. I appreciate CMS seeking feedback from organizations like ours and talking to us about this. I think it's an option that's been attractive to the hospitalists that are out there, and so as this program evolves and expands, we sort of want to make sure that we work with CMS to ensure that that's an approach that's at least available in some form of some flexible manner to those trying to participate. I will let Lauren wrap up and give you some directions as to how to access the recording and other things.
Okay, great. Thank you. We can go ahead and wrap up the question and answer session and also the webinar. Thank you very much to all the presenters for the excellent presentation, and also thank you to all the participants. If you have any questions that weren't answered in the webinar or anything in general about the presentation, please contact the AMDA Education Department. Our email address is education@paltc.org. This concludes today's program. Thank you all and have a good night.